Right. So, good evening again. I'm Dr. Seniru. I'm a specialist in internal medicine and happy to be joining you again for this journey through your exams and the uh, undergraduate learning program. In the last lecture, we had a lot of good feedback, but we realized that what you guys wanted more was a revision based theory sort of discussion rather than discussion of theory alone. So that's why we are bringing you the second session on medicine. So today I'll be discussing the rest of the paper that Dr. Lumar did last time for you, and we'll be discussing the rest of the questions in that paper today. Right. So for each, so we have 10 true false questions and 15 single best answer type questions again for you today. And I'll give you some time to answer each question, and then we can discuss on what each answer and the relevant theory part of that question is. And feel free to ask questions. You can, ask them directly, or you can post them in the chat that I may be able to see there. Right. So we'll move on to the first question. Okay, I think that's enough time for to answer this question. Right. So, in this question, we are talking about hypoglycemia. So, hypoglycemia in normal adults is different from hypoglycemia in patients with diabetes mellitus. And in when talking about hypoglycemia, you need to know what is the physiological response to fasting or reduce levels of glucose is, and based on that, we can answer these questions. So, when a patient experiences hypoglycemia, the first part may be asymptomatic, and then only you start developing the symptoms as the hypoglycemia worsens. So, when talking about hypoglycemia, there are two types of symptoms. There are, on one hand, there are autonomic symptoms like sweating, palpitation, dizziness, tremor, and a feeling of anxiety. And then on the other hand, you have the neuroglycopenic symptoms where these are due to direct lack of glucose to the brain cells like weakness, confusion, altered mental status, and even severe cases of in fact fit. And if the glucose falls very low, like about below 30-20, then you can have brain death also. So the first question is symptoms appear around 60 to 70 milligrams per deciliter. So anything below 70 we classify as hypoglycemia, but the symptoms of hypoglycemia or the autonomic symptoms are mainly due to the autonomic activation and the adrenaline secretion. So this happens when the sugar level falls below 55 milligrams per deciliter. So the answer to the first question is false. Then they are asking about why do neuroglycopenic symptoms occur. So for that, you need to remember your past physiology days regarding all the types of glucose receptors. So there are many types of glucose receptors. Main glucose receptors or glucose uptake receptors are known as GLUT receptors, GLUT. There are one to about six, seven types of receptors. So the ones that we are mainly concerned about are the GLUT4 receptors, which are the ones which are present in skeletal muscle as well as in fat tissue, which requires insulin for glucose to be taken into those cells, mainly the fat cells as well as the skeletal muscle cells. But the intake of glucose into the brain cells or through the blood-brain barrier is via the GLUT1 and the GLUT3 type of glucose receptors, which are not dependent on insulin. So, the insulin level is not responsible for the development of neuroglycopenic symptoms because the glucose intake entry into the brain cells is not dependent on insulin. So we would consider this one as false. So recovery is due to glucagon release. Right. Okay. So for this question, you need to know about what happens when you are developing hypoglycemia. So in a normal patient with a normal physiological response, the first thing that will happen when the glucose level starts to fall, it starts around when the glucose level is around in the 80s. So what happens is thus the insulin level will start to fall. Then only the second counteractive mechanism will take place where the glucagon will get released. So glucagon is a stress hormone compared to the other stress hormones also. And glucagon is responsible for counteracting the hypoglycemia. This stimulates glucose production either from lysis or from the glycogen stores in the liver, that is glycogenolysis, or by stimulating gluconeogenesis directly. So it also acts to reduce the level of insulin. So this we would consider as correct because glucagon is necessary for recovery of hypoglycemia. Then we have a statement saying concurrent hypopituitarism increases the risk. So when hypopituitarism is there, the the hormones that are necessary or secreted from the pituitary that are responsible for generation of the stress hormones like cortisol and growth hormone are deficient. So when there's hypopituitarism, you are at significantly higher risk of hypoglycemia at a lower blood glucose level compared to a patient who does not have hypopituitarism. So this is true. Then the next question is the threshold for the release of counter-regulatory hormones are similar. So as that is what I was describing earlier. So when the glucose level is around 80 to 85, your insulin level will start to fall. Then when your glucose level is around 7 to 75, your glucagon will start going up. Then the next thing to happen would be your adrenaline will or the epinephrine will start getting secreted. This starts when your glucose level is in between 65 to 70. Then the next thing that will happen is your cortisol and your growth hormone will get stimulated. This will happen when your the glucose level is between 60 to 65. And then only you will develop all your autonomic symptoms when the glucose level is below 55, and that will stimulate you to eat and uh, prevent you from going into further hypoglycemia. So the threshold for each of these counter-regulatory hormones are different. So you would consider this as false. So the answers for this would be false, false, true, true, false. Right. So moving on to the next question. Right. So you can try this one. Right. So the question is regarding Graves' disease. So you may remember that Graves' disease is an autoimmune disease that is causing significant problems to your thyroid gland, and it is due to TSH receptor antibodies, which are usually activating type of antibodies. So because of that, we see Graves' disease patients mostly with thyrotoxicosis, but that doesn't mean that always the antibodies are activatory. You can get Graves' disease with hypothyroidism and Graves' disease with euthyroidism also. So this type of antibodies are mainly TSH receptor antibodies that are activating antibodies, and they are of the IgG variety compared to the IgM variety. So because of this, because they are IgG antibodies, they have the potential to cross the placenta. And if you are a mother having Graves' disease, you can have goiter or even Graves' disease in the fetus or in the neonate due to the transplacental passage of uh, IgG antibodies. So this first statement is false. Next, they are asking about the eye signs of Graves' disease. Again, this is a very right. So in Graves' disease, you have a lot of eye signs. You can have proptosis, which can be seen from the front, or you can go from the back and see from up down to see whether the eyes are bulging out. Most often, the proptosis and exophthalmos refer to the same thing. Then you have lid retraction, periorbital edema, you have tearing, which can be made worse by cold, wind, or bright light exposures. You can feel a gritty sensation in the eye. You can get blurring of vision. You can get diplopia. You can get restriction of eye movements, and you can get color vision desaturation. So you see, there are a lot of eye signs and there are scales developed to assess thyroid eye disease because that can be considered an entirely separate entity when comparing the treatment of Graves' disease. So most of these signs are specific to Graves, but some of these signs are not specific to Graves, especially the signs such as lid retraction and lid lag, which can be seen in other types of thyroid toxicosis because it is due to increased sympathetic activation because you see the levator palpebral superioris muscle has a smooth muscle component and a skeletal muscle component because the smooth muscle component is primarily innervated by parasympathetic muscle, and when the sympathetic tone increases you can get this lid retraction and lid lag, which is not specific to Graves disease. Right. So you see, most often you get bilateral light signs, but unilateral light signs also can be seen. So if the stem was like unilateral eye signs can be seen, we would say it as correct. But here they are talking about general. So unilateral eye signs are seen, but so unilateral eye signs are not the general feature. So we would mark this as a false. Then moving on to we'll talk about the eye disease ones first. Moving on to stem D, commonly presents as a multinodular goiter. No, Graves' disease, you'll get a diffuse swelling of the thyroid gland that is usually small. So if you go into the history or if you are encountered with the history taking perspective in a patient with thyrotoxicosis, a small goiter that is for a shorter duration is more likely to be, and having features of thyrotoxicosis is more likely to be of Graves' disease, where there are large or long-standing goiter, which but having only thyrotoxicosis symptoms only for a short duration is more likely a multinodular goiter, transforming into a toxic multinodular goiter. So you see the duration of the symptoms as well as the duration of the goiter will be short in Graves' disease. So this is false. Oh, it presents as a diffuse small goiter. And there are certain things that can worsen the eye signs in Graves' disease. That is treatment of the eye signs of Graves' disease. So especially when you do radio frequency ablation or the radio iodine ablation for the thyrotoxicosis of Graves' disease, you can get worsening of the eye signs, and this can be also be seen in males and in smokers. So this is true. Moving on to C, so patients with thyrotoxicosis are usually managed with drugs that are anti-thyroid drugs. So anti-thyroid drugs have, there are three types of anti-thyroid drugs. You have the thionamides, which are, all three are thionamides. We have the carbimazole, we have methimazole, and we have propyl thiouracil. So what is commonly used and what we commonly have is carbimazole. So patients with thyrotoxicosis are usually managed with carbimazole, and we also give them beta blockers, something like propranolol, atenolol to reduce the thyrotoxic symptoms. But the situation is different when you are having a thyroid crisis or a thyroid storm, where you may have thyrotoxicosis for a certain amount of duration, and in the form of in the event of a precipitant, which can be an acute illness, which could be a surgery, or even some other types of illness, medications, you can go into a thyroid storm. So whenever you encounter a patient with thyrotoxicosis, you need to see whether this patient is in a thyroid storm or whether this patient is in an impending thyroid storm. So for that, you have certain features that you're going to look at, whether the patient is having fever, whether the patient is having hypopyrexia, whether the patient is having mental status changes, whether the patient is having abdominal pain, vomiting, deranged liver functions, and sometimes even jaundice, whether the patient is having diarrhea, whether the patient is having AF or heart failure. So all of these symptoms or signs can be classified together, and you have a scale that is known as the Birch Watofsky scale. So whenever you encounter a patient with thyrotoxicosis, You get your smartphone and put your MedCalc app, and then you see whether the patient is in a impending thyroid storm or a thyroid storm by putting in all the patient's parameters. So if the score is above a certain level, the patient is in an impending thyroid storm or thyroid storm and has to be managed like that. So when the patients are in the impending thyroid storm or thyroid storm, it carries very high mortality and morbidity and has to be managed very carefully by liaison with the endocrinologist if possible. So for that, we use higher doses. Sometimes we use IV therapy as well when you are using the anti-thyroid drugs. The what we prefer to use here is propyl thiouracil, but for less severe cases, you can even use carbimazole or methimazole. So along with that, we like to give them beta blockers in high doses, propranolol, which could be IV or oral. And then along with that, we give IV hydrocortisone. So IV hydrocortisone as a steroid, and it reduces the peripheral conversion of T4 to T3. So in the cells wise, T4 to T3 conversion is important for the T3 to enter into the cells and deliver the action of thyroxine. So along with steroids, antithyroid drugs, and beta blockers are a mainstay of treatment of thyroid storm. And in a selected amount of patients, we use other modalities to manage thyroid storm, which we can use iodine solutions, which is a combination of iodine and potassium iodide. Where what we commonly have is a thing called Lugol's iodine. We can use that. That can also reduce the uptake of iodine into the thyroid gland and reduce the thyroid toxicosis. And there are place for other drugs such as polystyramine, which is a bile acid sequestrant, and a drug called lithium, which is used as a mood stabilizer, and that can have place in management of thyroid storm if it's very severe. But these drugs will be only be used with the endocrinologist input. So the step C is true. So for this question, the first one you would consider as false, second one you would consider as false, third one you would consider as true, fourth one is considered as false, and the last one you would consider as true. Right. Okay, now you can try this question. Right, so we'll move on to the answer. So here we have a question about aplastic anemia. So for that, usually if you are asked about aplastic anemia, you will be asked regarding the etiologies of aplastic anemia, and because not much about the treatment of aplastic anemia. So for that, you need to know what aplastic anemia exactly means. So aplastic anemia is a a common cause of pancytopenia. So there are other causes of pancytopenia, but all causes of pancytopenia are not due to aplastic anemia. So we'll see what aplastic anemia is. Right. So aplastic anemia means there's a bone marrow failure due to hypoplasia or aplasia of the precursor cells in the bone marrow. So that does not mean that the bone marrow that means that the bone marrow cells are there, but there is reduced numbers or absolutely no numbers of the precursor cells. For that, the bone marrow has to be otherwise healthy. So there should not be any fibrosis in the bone marrow. There should not be any infiltration by any other substances in the bone marrow, and there should not be any reversible cause. So you see some drugs can cause aplasia for a certain amount of time, but we tend to give them some time to see whether the aplasia is not, whether the aplasia is reversible or not. So after certain time only you classify them as having aplastic anemia if you know that this is due to a certain drug, especially chemotherapeutic drugs. When you give them, you get a transient period of bone marrow aplasia where all the cell lines get suppressed. But the bone marrow may recover after some time after the chemotherapy. And until that, we won't classify that patient as having aplastic anemia. So there are most cases of aplastic anemia are due to acquired causes, but there could be some hereditary or inherited causes of aplastic anemia. So here are the etiologies of aplastic anemia that I have listed. So there it can be autoimmune causes, which are antibody mediated, like graft versus host disease, or in patients with SLE. Then it could be due to chemicals, which can be insecticides, toluenes, and it could be due to drugs like alkylating agents, antibiotics like chloramphenicol or sulfonamide, and drugs like methotrexate, which can be dose dependent. So higher the dose, higher the risk of aplastic anemia. And some drugs we have an idiosyncratic reaction where we don't know when the aplasia will occur or at what doses the aplasia will occur. So such drugs may include drugs like propylthiouracil, anti-epileptics, and chloramphenicol. So when you're treating patients with Graves' disease with carbimazole or methimazole, you can be very careful and warn them regarding this possibility of aplastic anemia, and to see whether to ask them to come to a doctor as soon as if they develop any fever, any cough, or any sore throat, or like that, to get a full blood count to check to see whether there is significant agranulocytosis or pancytopenia due to aplastic anemia due to propylthiouracil or carbimazole. Then other drugs which are notorious drugs which have idiosyncratic aplastic anemia is this drug called chloramphenicol and penicillamine. So hereditary wise, we have a lot of conditions. We have this dyskeratosis congenita, SOCH1 diamond, which may be important in your pediatrics. But what we want to focus here is this condition called Fanconi anemia, where you can have aplastic anemia and multiple musculoskeletal deformities, and so on and so forth. So idiopathic could be due to acquired stem cell defects, and infections are an important cause of aplastic anemia, especially viral infections like CMV, EBV, HIV, and this uh, category of viruses known as seronegative hepatitis or non-A to G hepatitis. That is the uh, hepatitis viruses that usually cause viral hepatitis. That is A, B, C, D, E, F, G. They are not the causes. There are other hepatitis viruses which may cause aplastic anemia and but not cause hepatitis. And there are certain peculiar conditions like anorexia nervosa, paroxysmal nocturnal hemoglobinuria, which goes hand in hand with aplastic anemia, and pregnancy also can cause aplastic anemia. So here you see that we are talking about aplastic anemia and not pancytopenia. So if this question was about pancytopenia, so most tips would be correct. But here we are talking specifically about aplastic anemia. So what does vitamin B12 cause? Vitamin B12 causes a megaloblastic anemia. So here sometimes you can get some degree of hypoplasia in the bone marrow, but what you commonly get is a megaloblastic sort of anemia, and it is not an aplastic anemia. So you would consider this as a false. Chronic liver cell disease can cause pancytopenia, but it does not cause aplastic anemia. So pancytopenia in chronic liver cell disease is commonly due to hypersplenism, where the enlarged spleen will trap all the cells and keep them inside without releasing them into the external circulation, and that will cause pancytopenia. So myelofibrosis, so chronic liver cell disease is false. It causes pancytopenia due to hypersplenism and not aplastic anemia. Myelofibrosis again is a cause of pancytopenia, but it is not related to aplastic anemia. If you have myelofibrosis, that is, you have fibrosis of the bone marrow, you cannot label that patient as having aplastic anemia. ITP is immune thrombocytopenia or idiopathic, yes, immune thrombocytopenia, where you get only a reduced amount of platelets in your circulation due to peripheral destruction of platelets rather than a production defect in the bone marrow. Then finally, you have Fanconi anemia, which is an inherited cause of aplastic anemia. So for this question, the answers would be false, 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 and finally true. Only the last one is true. Right. So you can try this one next. Okay. So This question is regarding spondyloarthritis and what are the typical features or associations of spondyloarthritis. So there are several types of spondyloarthritis. Spondyloarthritis typically involves your axial skeleton, and these are termed as axial spars. Then you can have spondyloarthritis that is affecting your peripheral joints, which can present as a peripheral oligo or even a peripheral poly sort of arthritis. These are termed as peripheral spars. Then you have spondyloarthritis associated with psoriasis. Yeah, you can label it as psoriatic arthritis. Then you can have spondyloarthritis associated with inflammatory bowel disease, or this is known as enteropathy associated uh, SPA. And you can have spondyloarthritis following infections, which can be genitourinary or respiratory tract or diarrheal infections, which is termed as reactive arthritis. So the classical features which are common to all these is involvement of the axial skeleton. So you get inflammation of the joints in your axial skeleton, which commonly presents as low back pain. So low back pain in young individuals has to be SPA has to be ruled out, because SPA is so whenever a patient presents to you with low back pain, you tend to prescribe them analgesics, and SPAs or spondyloarthritis are highly responsive to NSAIDs. So when you give them NSAIDs, the pain will disappear and the diagnosis will get uh, delayed, and the patient may present years later with deformities which are difficult to correct. So low back pain in a individual who is less than 45 years, you have to carefully rule out inflammatory arthritis. So compared to your diseases like rheumatoid arthritis, in spondyloarthritis, also you get an inflammatory type of low back pain where you get morning stiffness and the pain worsening after rest and improving after exercise. So along with this, you have with spondyloarthritis, you have a thing called enthesitis. That is, you have inflammation of the structures around the joint. Then inflammation that is not in the muscle and not in the bone, that is around the structures, that is in the tendons and the ligaments and the other structures. So a classical site of involvement of this is the heel, where you get heel enthesitis, plantar fasciitis, and maybe even conditions like Achilles tendinitis. So enthesitis is a classical feature of spondyloarthritis, so we consider the first one as true. So sacroiliitis is the classical axial involvement in spondyloarthritis, or the classical spondyloarthritis is the ankylosing spondylitis. So in ankylosing spondylitis, you will get sacroiliitis that is usually bilateral and may be evident on X-rays or MRI. So for that, you need to do a special X-ray called the X-ray sacroiliac joint, because you that is taken in a special way to see inflammation or ankylosis or joint space finding in the sacroiliac joint. But you can have radio negative or sacroiliitis also. Then the next question is about palatal ulcers. So palatal ulcers are not that typical in spondyloarthritis, but you can get palatal ulcers in other inflammatory conditions like SLE and Sjogren syndrome. Anterior uveitis, yes, of course, a red eye and a back pain clearly signals that the patient may be having spondyloarthritis or some other sort of vasculitic process which can involve the joints and the eye. So anterior uveitis is very common. So in any patient with back pain, you tend to ask about a history of red eye, because you are specifically concerned about anterior uveitis, and also you can get some sort of conjunctivitis also with ankylosing spondylitis. Raynaud's phenomenon is not that common with spondyloarthritis. It's more common with other rheumatological conditions like SLE, mixed connective tissue disorder, and scleroderma. So moving on to the other features of spondyloarthritis, anterior uveitis you see in about 25 to 45%. Skin, you can see the changes of psoriasis and the nail changes. In the gut, you may have diarrhea. You can get things like ulcerative colitis, Crohn's disease. In the lung, You can get restrictive lung disease. You can get apical fibrosis. So apical fibrosis, the mnemonic, uh, the ankylosing spondylitis is a cause of upper lobe fibrosis. Then you get obstructive sleep apnea with the scalded the heart. You can get a lot of regurgitant murmurs like aortic regurgitation, and in the kidneys you can get amyloidosis, and then they said induced nephropathy and IgA which are not that common. And you can also get corner equina because of spondyloarthritis. So next question is regarding bacterial meningitis. You can take a few minutes to answer this. Right. So this question is regarding bacterial meningitis. So bacterial meningitis is an important topic uh, in neurology, and it is a disease having high morbidity and mortality and has to be treated with utmost importance if you are suspecting. So meningitis, patients will have symptoms like fever, headache, and in the examination, and sometimes you may get seizures, cranial nerve palsies if there's very high increase in intracranial pressure. And in the examination, you'll examine to see whether there are any features of meningeal irritation. So we'll be examining to see whether the patient has neck stiffness and performing signs such as the Koenig sign and the Brudzinski sign. So lumbar puncture is a very important investigation in the management of bacterial meningitis, but because it can help tell you what the causative organism is and what the type of meningitis that the patient is having. And from the LP, you will be able to see whether the patient is having bacterial, viral, tuberculous, or fungal sort of meningitis. So early antibiotics are very important in the management of bacterial meningitis, and each day should be started as soon as you suspect bacterial meningitis. So it's best if you can do the lumbar puncture before the giving antibiotics, because as soon as you give some antibiotics, what you see on the lumbar puncture may get altered in the form of a partially treated meningitis. But if the lumbar puncture is getting delayed, you should not delay antibiotics. You should take a blood culture as soon as possible and start antibiotics after that. So antibiotics should not be started before lumbar puncture is false. So next thing is about the complications or the sequelae of bacterial meningitis. So in adults, in community-acquired bacterial meningitis, it usually goes with three common organisms. So Streptococcus pneumoniae is the commonest, and you have Haemophilus influenzae is rare now due to vaccination, and you have Neisseria meningitidis. And in immunocompromised patients, you may get other sort of organisms, and in extremes of age, you can get infection with organisms such as Listeria monocytogenes. So all of these can lead to sequelae, and specifically the one meningitis that is associated with a lot of bad sequelae is Streptococcus pneumoniae. It can lead to residual neurological deficit, seizures, coma, hearing loss, and so on and so forth. The other infections also can give rise to these complications. So because of that, we would consider the next one as true Haemophilus influenzae infection is associated with hearing loss. Right. So presence of a maculopapular rash is highly suggestive of meningococcal meningitis. Yes, of course, if you see a meningococcal sort of rash in a patient with a fever and headache, you should strongly suspect that the patient is having meningococcal sepsis, which can be rare, and the contacts also should be traced, and prophylaxis should be started because and for eradication of meningococcal carriers. And meningococcal sepsis is very bad because patients can deteriorate very rapidly and go into disseminated intravascular coagulation with adrenal hemorrhages. This is known as Waterhouse-Friderichsen syndrome. So meningococcal sepsis, if you suspect a rash, then that is highly suggestive. So that is true. So whenever you encounter a patient with meningitis, you tend to start the patient on empirical antibiotics because we don't know what we are dealing with. So for most cases, if you suspect that the patient is having bacterial as well as viral then meningitis or meningoencephalitis, you tend to start your antibacterial well as the antivirals together. So a broad spectrum antibacterial would cover most organisms. So what we'll tend to start is something like IV ceftriaxone 2 grams PD, which is a higher dose compared to what we use in other infections. And along with that, we tend to start IV acyclovir 500 milligram TDS if you're suspecting a viral etiology along with that. And after the lumbar puncture, you can safely discontinue either of these drugs. So, if you suspect listeria, listeria is not covered by ceftriaxone. You need to add additional antibiotics like ampicillin if you're suspecting listeria, especially in a extreme of age and immunocompromised individuals. So, along with this antibiotics, you need to give the patient IV dexamethasone, and these should be given along with the first dose of antibiotics or before the first dose of antibiotics. But in this day and age, it's likely that most of these patients may have received oral antibiotics prior coming to hospital from GPs, and the benefit of dexamethasone may be reduced. So this is to prevent the excess cerebral inflammation from causing further neurological damage and developing neurological sequelae. So what we tend to give is IV dexamethasone for about 4 days at around 0.15 milligrams per kilogram body weight every 6 hourly. So hydrocephalus is a complication. Yes, you can get obstructive hydrocephalus because of meningitis. And there are other complications of meningitis which are seen in this picture. You can get cerebral infarctions, you can get cerebral venous sinus thrombosis. So if you have a patient who's been treated for meningitis and develops headache later with seizures and which is a strong suspect is cerebral venous sinus thrombosis, and you can get subarachnoid hemorrhages and you can get intracerebral hemorrhages. So with respect to this question, the first statement is false, second statement is true, third one is true, fourth one is true, and the last one is true. Right. So another infection, leptospirosis. Can answer this. Okay, so the next question is regarding leptospirosis. So it's a very common infection in Sri Lanka and one of the most important differentials along with dengue that you have to think about in any patient coming with acute fever. So you have to ask carefully about lepto exposure. So with this could be working paddy fields, cleaning gutters, or dancing around in the rain or in the mud or in flood affected areas. So leptospirosis has some disease spectrum where it's caused by the spirochete known as the Leptospira interrogans, where there are about 20 serovas, and the most severe serova is known as the Leptospira interrogans enterohemorrhagicae. And the classical features would be fever, headache, and very significant arthralgia and myalgia. And most of the patients, this disease will be very mild and self-limiting. And these, because of this, we classify the patient as having two spectrums of disease as anicteric leptospirosis and icteric leptospirosis. And even in these anicteric patients, we are the first during the initial stages, you may have the headache, fever, arthralgia, myalgia, and then you have a significant conjunctival suffusion. So you can get conjunctival suffusion as well as you can, because of the low platelets, you can get spontaneous subconjunctival hemorrhages in leptospirosis. And in a minority of patients with this anicteric disease may develop the immune phase of leptospirosis where they can get a lot of immune manifestations and they can develop other complications of leptospirosis such as aseptic meningitis and uh, arthritis and so on and so forth. So uh, the 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 next minority would be having the icteric form of leptospirosis, which is the severe form of leptospirosis, or known as Beale's disease, where the patients will have renal and lung involvement. So the patients will go into acute renal failure, and the patient will go into drastic lung involvement in the form of pulmonary hemorrhages. So you need to be on the lookout for which of these patients would be developing this. And Patients with Wheels disease will also have uh, significant liver involvement with transaminitis and sometimes even going into fulminant hepatic failure. So the first question is about neck stiffness is a clinical feature. Yes, with the immune manifestations of aseptic meningitis can occur in patients with leptospirosis. The next question is regarding acute kidney injury in leptospirosis, which is relevant to the topic that we discussed that day. So we discussed about oliguric and non-oliguric acute kidney injury, where oliguric acute kidney injury is most often due to glomerular damage, whereas non-oliguric acute kidney injury is most often due to tubular and interstitial damage. So what sort of damage does occur in leptospirosis? So the classical manifestation or the renal involvement in leptospirosis is a acute tubulointerstitial nephritis. So you may be able to see some cast in the urine, some protein, and in the red cells also in urine. So microscopic hematuria is a entity that we are looking for in the UFR in patients with acute fever to see whether the patient may be who may be having leptospirosis. So having red cells in the urine in a patient with acute fever without any urinary symptoms may hint that the patient may be having leptospirosis. So along with that, patients with leptospirosis can have significant nausea, vomiting, diarrhea, and they can have myocardial complications if they are having significant Beale's disease like myocarditis, and they can go into shock because of this losses as well as the cardiac involvement. And because of the shock, patients may have renal underperfusion and can go into severe acute tubular necrosis of the kidneys also. So ATN also can occur along with AIN, both of these which can cause non-oliguric acute kidney injury. But sometimes the blood pressures may be so low and the patient may be on inotropes that the patient may be having oliguric acute kidney injury. So when you're monitoring patients with leptospirosis, it's very important to monitor both the creatinine and the urine output because most of the significant proportion of these patients may be having non-oliguric acute kidney injury. So this is true. Conjunctival suffusion is a feature we discussed this earlier. That is true. And active urinary sediment is a common feature. Yes, of course. You can have cast, you can have some protein, you can have some red cells in patients with leptospirosis because of the renal involvement. So leptospirosis treatment will be mainly will be like confirmation of the diagnosis with an accurate history, and you'll be sending off investigations. If you are in the early days, you can send off lepto PCR in the first 5 or so days, and after the first 5 to 7 days, you can send leptospira antibodies or the leptomat test. And treatment is usually the minor cases can be treated with oral antibiotics such as doxycycline, and severe cases may need IV antibiotics along with doxycycline in the form of cephalosporins or maybe even carbapenems in severe cases. So most of these bad manifestations of leptospirosis, Beale's disease, and so on and so forth is due to immunological processes. So when the patient is having significant pulmonary hemorrhages or renal involvement, and especially pulmonary hemorrhages, patient may benefit from immunomodulatory therapy. So in the patient who is having leptospirosis and pulmonary hemorrhages, there you can suspect when the patient is developing increasing tachypnea or maybe having frothy sputum or coughing out blood and having diffuse chest opacities that may be worsening each day when you image them successively. And in those patients, you should start the patients on immunomodulator therapy, which is sometimes given in the form of IV methylprednisolone pulses, or they can even benefit from things like plasma exchange. Again, the evidence for most of these are conflicting, but these patients are bad, so we tend to try whatever we can when we are encountered with such bad patients. So the last question is regarding disproportionate increase in serum urea than that of creatinine is common. So there are certain conditions. So urea uh, versus creatinine. So both are toxic metabolites of the kidney, and disproportionate increase in urea occurs when there is pre-renal azotemia, that is pre-renal losses. So in leptospirosis also, as I mentioned earlier, pre-renal significant quantity of pre-renal can occur, but most of the time it is due to a renal damage, either due to ATN or AIN rather than a pre-renal injury. So disproportionate increase in serum urea can also occur when there is increased urea genesis. That is either by a high protein intake, high catabolism, or things like a gastrointestinal bleeding, where there is a lot of blood that is proteins that is absorbed into the blood, and that can cause increased urea. So this is false for leptospirosis, because what we commonly see is proportionate increases in urea and creatinine, because most of the time it's a kidney injury that is renal in origin rather than a pre-renal cause. So for this question, the answers would be true, 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 and false. Right. So an easy question next. We'll try this quickly. Right. So this is regarding genetic disorders. So we have Huntington chorea is an example of a trinucleotide repeat mutation. Yes, so Huntington chorea is one hereditary form of chorea which can have other neurological manifestations, and it's there's no cure for Huntington's chorea, and it runs in families. So it's autosomal dominant inherited disorders, and it has this particular feature called as a trinucleotide repeat mutation of the CAG variety. And in these disorders with trinucleotide repeat mutations, with successive generations, the trinucleotide repeats keep getting added. So with the trinucleotide sequence getting expanded, with each generation, you will have more severe symptoms and a lesser age of onset. So this process is known as genetic anticipation. So anticipation is seen in Huntington chorea. So other trinucleotide repeat mutation disorders may include disorders like myotonic dystrophy type 1 and Fragile X syndrome, and diseases like Friedreich's ataxia, and maybe some cases of spinocerebellar ataxia. So this is true. So the next question, mothers with autosomal dominant disease transmit the disease to 25% of their offspring. No, that is false. So if you have autosomal dominant disease, so supposing that the father is a normal individual, you will transmit the disease. So if you can transmit either the healthy gene or the unhealthy gene. So if you, so there's a 50-50 chance of the disease getting transmitted to the offspring. So there won't be any carriers. 50% of them will be diseased and 50% of them will be normal. So this is false. Males are not carriers in X-linked recessive diseases. So males have only one X gene, and if they have the gene in that disease, they will not become carriers. They will manifest the disease. So males are not carriers in X-linked recessive diseases. Yes, it's true. Mitochondrial diseases are inherited from the uh, paternal side. No, wrong. Mitochondrial diseases or mitochondrial genes are transmitted from your maternal side, and they have mitochondrial diseases can have cardiac manifestation, neurological manifestations, ocular manifestations, and diseases may include diseases like birth, MELAS, and so on and so forth. Yes, so that is false. Skipping generations is a feature of autosomal recessive inheritance. Yes, sometimes you may not see the disease or the carrier state being manifested in a generation, but somewhere down the line, there may be cross linking between two carriers, and you may see a disease individual being generated. And so, skipping generations is a feature of autosomal recessive inheritance. True. So, for this question, true, false, true, false, true. Right. So again, an easy question. Can quickly answer. So this is quite an easy question. So we are talking about hormones that increase in stressful situations. So we're particularly talking about acute stressful situations. So cortisol is the stress hormone, so that is increased. And thyroxine, with stress, it stimulates your hypothalamus to release TRH, and your thyroxine will get secreted, and that will increase your basal metabolic rate and working synergy with cortisol. But when the stress is very severe, sometimes the hypothalamus pituitary axis can get suppressed. So in patients with very severe disease or stresses. You may see this thing called sick euthyroidism or uh, uh, thyroid disorders associated with non-thyroid illness. But for this question, we would consider this as true. Insulin is wrong. It's an anabolic hormone that is secreted and it will result in your glucose being stored in all your unnecessary tissues. And it is false because in stressful situations, or the hormones like glucagon will be more prominent rather than insulin. So this is false. Prolactin, yes, it's due to physiological as well as emotional stresses. Your prolactin level will increase. So, whether that is helpful or not is another question, but it will increase in your stressful situation. So, prolactin will be true. Growth hormone is again true, especially in cases of stress. Uh, it increases and it helps in situations like hypoglycemia and it helps in raising your blood glucose level. So, for this question, true, true, false, true, true. Next question. Right. Right. So this question is regarding the renin angiotensin aldosterone system. So we will see about that system and then go into the answers. So renin is the main starting point in here. So the renin-angiotensin system, renin is released from the kidneys when there's a drop in blood pressure. This is sensed by the intrarenal baroreceptors as well as the baroreceptors. And the drop in fluid volume or reduced sodium level will reduce in result in it be sensed at the macular densa level, and that will stimulate your renin secretion and also increase sympathetic activity when you have stressors as well as so renin can be considered as another sort of hormone that gets stimulated during stress. So when you have dehydration, blood loss, so other increased sympathetic activation, you can get renin getting secreted. And so when renin gets secreted, what will happen is it will convert the angiotensinogen that is produced in the liver to form angiotensin. So when angiotensin is formed, one is formed, it gets converted to angiotensin 2 with this enzyme called angiotensin converting enzyme or ACE, which is usually present in the uh, blood vessels in the lung and it can be found in blood vessels elsewhere also, but is more prominent in the lungs. So main action of angiotensin 2 is on several organs. It can act on the adrenal gland to stimulate the release of aldosterone, and it can directly act on the kidneys to increase the sodium absorption. And via aldosterone, also it can act on the kidneys to stimulate reabsorption of water. And angiotensin 2 also directly acts on the blood vessels, stimulating vasoconstriction. So this is the pathway. So we'll see the answers. So renin secretion is induced by ANP. So ANP stands for atrial natriuretic peptide. So what will happen with that is it will cause more natriuresis to occur. So renin secretion is not stimulated by ANP. If so, it has to be inhibited by ANP. So this is false. Angiotensin 2 is produced by the in the liver. No, angiotensinogen is the thing that is produced in the liver. Angiotensin 2 is produced in the mainly in the lungs because of the presence of ACE. And angiotensin 2 stimulates the ADH release from the hypothalamus. Yes, in addition to what we discussed, because angiotensin 2 via aldosterone stimulates sodium reabsorption, and so the water component also has to get reabsorbed. And after that, ADH will stimulate the water reabsorption along with the sodium reabsorption. So this is true. Aldosterone acts on the distal convoluted tubules. The main action of aldosterone is on the principal cells in the cortical collecting ducts, and it can these cells can be there in the late part of the distal convoluted tubules also. So because of that, because the main action is on the cortical collecting ducts, we would mark this as false. So activation of RAS is beneficial in chronic heart failure. No, activation of RAS is can be beneficial in acute heart failure, but it acts as a compensatory mechanism and with for chronic heart failure. But in the long run, this will tend to uh, uh, we go into overdrive and cause more fluid and more fluid retention and cause worsening of heart failure. So we would mark this as false. So for this question, we would mark this as false, false, true, false, false. Last true and false question. Again, an easy question. So we have only a little bit of time left, so we need to rush through these questions, right? So we'll try to answer this. So thiazides. So what the common thiazide that we use is the drug called hydrochlorothiazide, and there are other thiazides like indapamide and clothalidone that are not freely available in the government sector here, but what we commonly use is hydrochlorothiazide. So thiazides can be used for multiple reasons, but the most common indication that we use thiazide is for hypertension control. So thiazides are a notorious cause of hyponatremia. So especially when used in elderly, this can be this can cause very significant hyponatremia. So the first answer is true. It increases the potassium level. No, thiazide is a potassium losing diuretic similar to furosemide, and it will cause low potassium, whereas increased potassium is seen with diuretics like spironolactone. Thiazide will cause reduced serum uric acid level. No, it is false. Thiazides can precipitate gout by increasing the uric acid level. So that is false. Thiazides cause increased serum calcium level. Yes, that is true. Thiazides can cause increased serum calcium level by stimulating the calcium reabsorption as well as causing hypocalciuria. And the last, so that is true. The last stem is thiazides cause increased serum pH. So along with the hypokalemia and the fluid loss with thiazides, you get a contraction, alkalosis, and that will cause an increased serum pH. This is usually evident with other diuretics also like furosemide, where you can get an alkalosis. So the answers to this would be true, false, false, true, true. Right. Moving on to SPAs. Right. You can try this. For these questions, if anybody else is up for answers, you can type them in the box because these are sort of difficult questions with 2 or 3 correct answers, and we have to get to the um, most suitable answer. Right. So we have some answers here. So interesting. So right. So we have a 40-year-old male with type 2 diabetes mellitus for 22 years on metformin, glycoside, and sitagliptin, which are the usual drugs that we have in the government sector, but they are maximum tolerable doses. They came to the medical clinic with the following blood sugar series results, and HbA1c is 9.5. So that means that the long-term control of diabetes is not that optimal. Serum creatinine is 84. That means the renal function is important. They ask him what is the best intervention to improve his glycemic control. So let's see what these are. So we have 2 blood sugar series. In the first series here, we have a fasting blood sugar that is 185. That is abnormal. So for diabetics on good control, we would like to maintain the pre-meal insulin, pre-meal sugar in between 80 to 130. And the post-meal sugar that is usually taken 2 hours after, we would like to control it below 180. So 80 to 130 pre-meal and below 180 post-meal. So that is the idea. So let's see what these are. So post-breakfast 182, a little high. Pre-lunch 192, high. Post-lunch 357, very high. Pre-dinner 187, again a little high. Post-dinner 186, a little high. So here again fasting is high, post-breakfast is a little high, pre-lunch is high, pre-dinner is high, post-dinner is a little high, but the post-lunch is the highest spike. So if you see all this, the general observation is that the fasting blood sugar is not that adequately controlled. Both the pre-lunch and the pre-dinner is not that adequately controlled, but the post-breakfast and the post-dinner are almost adequately controlled. But the largest problem is in the post-lunch uh, uh, CBS values. So whenever type 2 diabetic patients uh, come with these sort of results, but for their better compliance and for their better adherence to therapy, we would first like to start the patient on a single dose of insulin rather than having multiple doses of insulin. So options would be going for a single basal sort of insulin or going for whatever the largest meal of the patient is, whether it's breakfast, lunch, or dinner, and seeing whether the postprandial blood sugar gets controlled. So the problem that we have here is the very high spike the post lunch, right? So what is the best intervention to improve his glycemic control? So acarbose before lunch can be helpful, but it will not bring down this much of blood sugar and it has a lot of bad side effects. So once daily isophane insulin, it's again a very good option. It will result in control of most of these blood sugar series, but it will not help particularly with that post-lunch spike. Then we have two similar options, lunchtime rapid acting insulin and lunchtime soluble insulin. We will keep them apart. And adding SGLT2 inhibitors, yes, can be beneficial, but the HbA1c reduction is that not that optimal with SGLT2. It's maximum about 0.5 to 1%, maybe hopeful cases more than 1%. And it may be helpful here, but it does not particularly deal with the problem that we are having. So the options that we are left with is lunchtime rapid acting insulin and lunchtime soluble insulin. So those are the two options that you have chosen. So soluble insulin compared to rapid active insulin, soluble insulin has a longer sort of duration and a slower onset of action, and we want to tightly control this post lunch uh, insulin or the blood sugar surge, and therefore the best answer would be a lunchtime rapid acting insulin, that is C. Right. So here we have a 45-year-old female who presented with confusion, abdominal pain, and vomiting. Could be due to any reason. And we are given more information that she's on treatment with thyroxine for hypothyroidism for 5 years with recent weight loss. So hypothyroidism patients with recent weight loss, you should think whether the patient is being over-treated and whether the patient has gone into thyrotoxicosis, and which can contribute to weight loss. She's unwell and her blood pressure is 90 by 50. So that could mean that the mean arterial pressure is not 65 uh, millimeters of mercury and the patient is in shock. So her investigations are listed as below. Her sodium is 129, which could be due to vomiting, but the potassium is 5.9. So if you have persistent vomiting alone, you are expected to have hyponatremia with hypokalemia. But here you have hyponatremia with hyperkalemia, which suggests or which can hint whether this patient is having an adrenal pathology. So when you have hypoadrenalism, you get low mineralocorticoid activity, you get low sodium and high potassium. And is the clinical picture fitting with an Addisonian crisis? Yes, confusion, abdominal pain and vomiting, and low blood pressure with weight loss with these electrolyte abnormalities is adrenal insufficiency. Does she have risk factors for adrenal insufficiency? Yes. She's having hypothyroidism. That means she's at increased risk of autoimmune conditions, which is most likely a autoimmune sort of hypothyroidism like Hashimoto's thyroiditis, and they are at more risk of developing other autoimmune disorders, including adrenal crisis. So serum creatinine is 103, that is normal. Blood urea is 7.6, that is possibly due to vomiting and the pre-renal azotemia. TSH is 3.5, that is normal, and T4 is 7, again that is normal. So that would suggest that the patient is adequately treated for the hypothyroidism, and hyperthyroidism is not the cause of weight loss. So CT brain is normal. So we are dealing with an Addisonian crisis here. So they are asking about what is the first step in the management. So IV normal saline bolus, yes, seems like a good option. IV dextrose infusion, not that necessary if the patient is having concurrent hypoglycemia, again, may be important. IM glucagon, not that good of an option. IV hydrocortisone, yes, can be helpful because the patient is in episodic crisis. And finally, IV calgluconate, which may not be that helpful. IV calgluconate is only given in cases of hypocalcemia or patients with like hyperkalemia who are having cardio ECG abnormality. So the options that we are left with is IV normal saline bolus versus IV hydrocortisone, A or D. So what we give first is again a good question. But what we tend to give in these sort of situations is we tend to give both of these together, like because we don't like wait until you give this. So we just pump IV hydrocortisone and start fluid so pump hydrocortisone. So the correct answer depends on who sets the question. And so 50-50 for IV normal saline bolus and IV hydrocortisone. One could argue telling that the blood pressure is low, and in such situation, you should consider the patient to be in shock and prefer a IV normal saline bolus first after IV hydrocortisone. But in reality, we would be giving both of these together. So if you really want to pick one, again, it would be very difficult to see whether it's A or D. So depends on who sets the question, the answer would differ. Right, we will go into the question. So here we have a 56-year-old patient with type 2 diabetes mellitus on metformin 500 milligram TDS, presents with an extensive anterior myocardial infarction. His HbA1c was found to be 7.9%, not ideal. What is the most important step at this point to improve his survival? So you have to note the wording at this point. So we are talking about a patient who is having a very bad myocardial infarction who is on metformin. So patients with very severe illness, either organ failures or very bad sort of state with cardiac, renal or liver impairment, we tend to take those patients off metformin because the glycemic control can be aberrant with metformin, as well as patients may not be on a good diet, and patients metformin can cause anorexia, as well as the most important reason why we are taking these patients off metformin in the acute state would be the theoretical risk of lactic acidosis in patients with severe illness when you are using metformin. So you need to take the patient off metformin, but you need to tightly control the blood sugar, because uncontrolled blood sugar in a patient who is having an extensive myocardial infarction will have worse prognosis and can even lead to morbidity and mortality. So let's look at the options. Strict diabetes control, yes, of course, that is important, but controlling the diabetes strictly will be helpful in preventing patient getting another myocardial infarction, but not this myocardial infarction. Start soluble insulin looks like a very good option because we can tightly control the patient's blood sugars. Start glycoside, yes, can be a good option, but will not have a survival benefit on this patient's cardiovascular status. Start sitagliptin again would be the same. Start empagliflozin, yes. In the long run, empagliflozin will be beneficial in patients with diabetes and significant cardiovascular mortality, maybe ischemic heart disease, maybe heart failure, or maybe things like stroke, peripheral vascular disease. In diabetic patients with this significant cardiovascular disease, empagliflozin may be beneficial, but empagliflozin will only act in the long run to prevent cardiovascular mortality. So the only sensible options here would be A, B, and D. And out of that, B and D seems like the sensible options, but we are talking about at this point. So the patient is having an acute myocardial infarction at this point. And so the most important step at this point to improve his survival would be to start the patient on soluble insulin and strictly control the blood sugar. So the answer would be B. Right. So we will go into the answer. Again, a difficult question. So a 40-year-old woman presented with fever for 2 days and few ecchymotic patches. She is otherwise normal. The following investigations were carried out. Hemoglobin 12, WBC 6.4, platelets 20,000, INR and APTT is normal. So what is the most appropriate diagnosis? So dengue hemorrhagic fever. mm, Patients with dengue hemorrhagic fever presenting within the first 2 days with a platelet count of 20,000 is a little abnormal, and patients in day 2 of fever usually develop leukopenia rather than this normal amount of white blood cells that you observe here. And if the patient has ecchymotic patches in dengue hemorrhagic fever, usually patients will be more ill, but the patient is otherwise normal. But if you had a stem saying whether this is dengue fever, again, what will be not classical here would be the very low platelet count in day 2 of fever. DIC is of course out because DIC patients will be very ill and DIC patients will have prolongation of the INR and APTT. So that is out. Then when you consider ITP, seems like a sensible option. So patients with ITP can present with viral infections. This may be the first time that patients may get a full blood count done, and this low platelet can be a incidental finding. And ITP can be triggered by viral infections, and the viral infection itself may cause the patient's platelets to fall from a relatively stable level around below 100 to a very low level. So that can be the what is happening here. And TTP again can happen with low platelets, but patients with TTP will have thrombotic thrombocytopenic purpura, so they will have neurological manifestations, they will have kidney manifestations. Again, patients will be more ill. Similarly, patients with Henox online purpura will have ecchymotic patches everywhere. They can have renal failure, and patients can be very ill. So I would say out of all the options, patients or the reliable options would be things like C and E. Dengue also can be considered, but out of all this, in a relatively well patient who is 40 years old with fever for 2 days and few ecchymotic patches, we would go for a patient having ITP, that is C. Right. This is an easy question. Okay. Right, so here we have a patient who is 27-year-old female presents with fever cough for 3 days. She was pale and had ecchymotic patches over the extensor surfaces of the arm. So fever and cough and having some bleeding manifestations and anemia. Full blood count results are as follows. HP is 8.9 low, WBC is 2.6 low, platelet 65,000 low. So she is having pancytopenia. Bone marrow biopsy, bone marrow replaced with fat and lack of progenitor cells. So this is classically what we described earlier, and staining with fish did not reveal any features of hematological malignancy. So going from bottom to top, hemophagocytosis following infection is possible, but you will see some evidence of hemophagocytosis in the bone marrow. This is what is known as HLH, which could be either primary or secondary to infection. In myelofibrosis, you will see the so hemophagocytes will be macrophages engulfing your red cells and the other cells causing pancytopenia. Myelofibrosis, the bone marrow will be replaced by fibrosic tissue. So we don't have such a bone marrow here. So it's out. Autoimmune hemolytic anemia, the bone marrow will be normal and there will be peripheral destruction of hemoglobin. When autoimmune hemolytic anemia, you will not expect the other cell lines to fall. So if you have autoimmune diseases in more than one cell line, you will call the patient as having Evans syndrome. Iron deficiency anemia again will not classically cause pancytopenia, and aplastic anemia is the correct answer. Right, again an interesting question. We have a 70-year-old woman who is a known patient with osteoporosis on treatment with alendronate and calcium supplements for 2 years. Came with a vertebral fracture. So she's on treatment and we assume that there is good compliance. So there was further deterioration from the initial DEXA scan. So this can happen because the osteoporosis process is itself not that adequately controlled with alendronate, or could happen because of other factors being there. The laboratory investigations are as follows. Calcium is 1.3, that is low. Phosphate is zero point 0.7, that is low. So both calcium and phosphate are low. Serum creatinine is 100, that is normal. PTH is 58, that is mildly elevated. So patient has some form of hyperparathyroidism. So whether this is primary, secondary, or tertiary is the one that we have to determine here. So in both primary and tertiary hyperparathyroidism, you would expect the patient's calcium to be high. Here the calcium is low. So this could be a form of secondary hyperparathyroidism stimulated by the low calcium level. So I have to determine why this patient is having low calcium level. So patient's calcium and phosphate are both low. That is a feature of patients with osteomalacia or vitamin D deficiency. But the other options here also seem sensible. HRT will be important in management of osteoporosis, but will not be that effective as alendronate. So if we want to start, if this calcium and everything was normal, if we wanted to start an alternative agent, we may need to start other agents like denosumab and so on. So zoledronic acid is the IV form of alendronate, and almost of similar efficacy, but will be more easier to administer. Increasing the dose of the calcium supplement will not help that much with the will help that much with the hypophosphatemia, because the more calcium you give, your phosphate will get binded and your phosphate level will further go down. So that will only increase the calcium level. So vitamin D level checking. So osteomalacia or vitamin D deficiency is very common in elderly patients, especially in the Sri Lankan setup. So most of these patients are deficient on vitamin D. So this will look like a most appropriate option. So what about A? Yes, A is also a good option because magnesium is essential for the parathyroid sensing of the calcium level. So checking the magnesium level is also important, because if there is underlying magnesium deficiency, you should correct that for your PTH response to be appropriate to the level of hypocalcemia. But hypomagnesemia is less common than vitamin D deficiency. So we would first check the vitamin D levels along with checking the magnesium levels, but we would go for the commoner option here by checking the vitamin D levels and correcting the vitamin D levels. Right, so the answer would be B. Right, again, uh, right, we have different answers popping up. Okay, so here we talk about typhoid. A 64-year-old lady presented with a 10-day history of constipation, abdominal pain. On examination, there was a mild pallor, generalized lymphadenopathy, and a right lower quadrant mass. There was no hepatosplenomegaly. Which of the following findings make a diagnosis of typhoid? Uh, say typhoid unlikely. Okay, which of the following findings make a diagnosis of typhoid unlikely? Okay, right. So typhoid is again a common illness, and that we have to suspect in patients who have significant exposure to typhoid contents, that is contaminated food and water, and also in patients presenting with PUO. So typhoid would classically have in the pre-antibiotic era have a week-wise progression of symptoms, where the first week you will have fever, headache, vomiting, and abdominal pain, where the fever would be a step ladder, so sort of rising sort of fever. By about the second week, you will start developing abdominal pain, and you will get all these patches in your tummy that is called as rose spots. And by the third week, the patient will develop constipation and severe abdominal pain, perforation, and by about the fourth week, patient will be in encephalopathy or severe sepsis. But this classical week-wise progression is not seen in this antibiotic era. So splenomegaly is a common finding in typhoid, and we generally tend to look for a spleen when we are looking for a typhoid. But however, you can have typhoid without splenomegaly. Constipation can be seen in some stages of typhoid, particularly in the third week or so. Sometimes even diarrhea can be seen in typhoid. Generalized lymphadenopathy, not that common. We would expect localized mesenteric sort of lymphadenopathy in patients with typhoid, but there are patients who have been diagnosed as having typhoid who have generalized lymphadenopathy. But if you have generalized lymphadenopathy, we do not think of typhoid as the first and foremost thing. We would think of something like lymphoma, tuberculosis, things like that. So pallor, so typhoid is almost a subacute chronic sort of condition. So you can get pallor with typhoid. And right iliac fossa mass. So typhoid in the pathogenesis, you have the typhoid organism, which is Salmonella typhi or Salmonella paratyphi, and we have other non-typhoidal Salmonellas also. And the enteric fever one is the Salmonella typhi type, and that gets into your bowels, and in the small bowels it re-enters there and it infiltrates your Peyer's patches. So in the Peyer's patches, you can get significant collections there, and that can be sometimes be palpated or can lead to perforations, localized septic foci, and sometimes it can be palpated as a right iliac fossa mass. So uh, B, D, and E are of course out, so we are left with A and C. So out of that, it would make it less or unlikely would be a generalized lymphadenopathy. So we would go for C here. Right. So again, an easy question. Okay, so we have a 54-year-old diagnosed patient with diabetes presenting with fever, dry cough, frontal headache, and myalgia for 5 days. An examination, he had a pulse rate of 110 and temperature of 102. Lungs are clear. So we are talking about a patient who is having acute fever with very high pulse rate, as a dry cough, headache, myalgia, fever, which can happen with most of these infections. So, but the important thing here is the WBC count is high and it is lymphocytic, and there's a marginal thrombocytopenia. So, what is the most likely cause of this? Dengue virus will can cause a lymphocytosis, but it will usually not cause a very high WBC or a high WBC count like this. You would expect the patient to be having leukopenia with relative lymphocytosis rather than an absolute lymphocytosis like this. Influenza virus, yes, a very good option. Can have dry cough, frontal headache with clear lungs, and can have lymphocytic picture like this with low platelets because it being a virus. Leptospirosis, you can have high WBC with low platelets, and the feature will also fit a leptospirosis, but it will be a neutrophilic predominance rather than a lymphocytic predominance. Salmonella typhi, again, will be more neutrophilic in origin, and you can have leukopenia also in patients with, that is, you can have low WBC or you can have high WBC, but it will predominantly be neutrophilic, and you don't expect patients to develop cough and this much of myalgia with patients with typhoid. And streptococcus pneumoniae would classically cause lobar pneumonia, and so because of that, this patient's lungs being clear and the patient having other symptoms and the patient having a high lymphocytic count is against the patient having streptococcus pneumoniae. So the correct answer would be B, influenza virus. Next question. Right. So we have a patient with paracetamol poisoning here. A 16-year-old boy with nausea, vomiting, and abdominal pain. He has taken 4 tablets of paracetamol. That's almost 2 grams of paracetamol 4 hourly during the last 36 hours for a headache. So that would say patient would have taken 6 times per day. That is 2 grams 600. Patient is taken about 12 grams per day of paracetamol. He has presented with nausea, vomiting, and right hypochondrial tenderness. And the plasma paracetamol level was measured and it was below the treatment threshold. What is the normal? What is the next step in the management? Reassurance is of course out. So we are talking about the staggered overdose or repeated supratherapeutic injection. So with repeated supratherapeutic injections, what you have to remember is the paracetamol levels is not uh, that reliable. And so for acute injections only, or the acute single dose injections, this Rumac-Matthew nomogram or the nomogram is validated. So plotting the serum paracetamol level in nomogram in 4 hours is obviously out. Then we have other things called administering activated charcoal. So administering activated charcoal is only beneficial if the patient presents very early within the first 2 to 4 hours. So if you want to give charcoal, you give charcoal of about 1 gram per kilogram of maximum 50 grams. Starting neck infusion and oral methionine so are the available options. So methionine is not validated for repeated supertherapeutic injections, and which methionine is not effective. The patient is having significant nausea, vomiting, if the patient is having significant liver derangement, and if the patient is so far beyond the illness, like this patient where the patient is about 4 days into the illness. So the viable option here would be starting a neck infusion because the patient fits the criteria for repeated supratherapeutic injection, as well as patient has signs and features of impending liver dysfunction. So when you consider acute injection of paracetamol, the liver dysfunction will only start to appear after 48 to 72 hours. So if you measure the AST/ALT and all the things at the beginning and during admission, you need to repeat them daily to see whether the patient is developing liver injury. And sometimes the liver injury may be so severe that the patient may need a liver transplantation. So the correct answer here would be starting a NAC infusion. Again, a very easy question. Go into the answer because time is running out. A 24-year-old woman on multiple drugs for psychiatric illness was brought to the hospital by her family members with suspected poisoning that had occurred about 2 hours ago. She was severely drowsy and the saturation was 84 on room. Her pulse rate is 110, blood pressure is 90/60. What is the most appropriate next step in the management? So when talking about patients with poisoning, you have to manage them in the same way as the ABCD approach. So first thing is to secure the airway. So the patient is having severely been drowsy and the saturation is in 84. So you have to secure the airway and assist the patient's breathing because that would kill the patient first. So giving activated charcoal in a very drowsy patient will be very risky. Endotracheal intubation seems like a good option. Gastric lavage is again very risky if you are dealing with a very severely drowsy patient. Induced vomiting is again risky, that can have aspiration. So the correct answers would be endotracheal intubation and non-invasive positive pressure ventilation, which would both help with improving the patient's oxygenation. But because the patient is severely drowsy, patient is not able to breathe and that very well, and patient will not tolerate NIV. So in this sort of patients, we would have to electively intubate the patient without a delay to secure the airway. So the correct answer would be B. Right. Okay. Something about a snake bite. Okay, so we have some answers coming up. A 40-year-old fisherman from Jaffna presented with a snake bite on his right foot 3 hours ago. There was swelling at the bite side, so there's some local reaction. There was no overt bleeding, but however, the 20-minute whole blood clotting time was prolonged. No neurological symptoms were present. So, what is the most likely snake that he had got bitten by? Cobra, common thread, rhesus viper, sea snake, saw scale viper. So, we are talking about a patient from Jaffna. In Jaffna, all of these serpents could be there. So, for this to answer this question, we need to think about the geography as well as the manifestations of different snakes with snake bite, right? So with Russell's viper bite, we will first focus on cobra and crate bite. So with cobra and crate bite, you will get a lot of neurological manifestations, but the key feature would be differentiating these two would be cobra will have a local effects or local reaction severely, where crate will have minimal symptoms locally. All the vipers can cause coagulopathy, but the most significant coagulopathy will happen with Russell's viper, and then with the saw scale viper, and then finally with the hump nose viper. So all of these can cause prolongation of the WBCT. And with the respect to the local effects, the Russell's viper, scale viper, and the hump-nose viper all can cause local effects. And if you're dealing with a sea snake, there won't be any local effects of coagulopathy. There will only be muscle problems leading to rhabdomyolysis. And this can manifest as neurological manifestation. So, what is the correct answer here? So cobra is definitely out because there are no neurological symptoms. Crate is out because there are significant local reaction. Sea snake is out because of this. So the what we are left with is Russell's viper and scale viper. Both can be present here, but here the uh, things to go by would be that there are no neurological manifestations and the patient is relatively well despite the whole blood clotting time being prolonged. And patient is from Jaffna as well, and the patient is with a fisherman. So we would go for a viper bite that is less severe than a Russell's viper bite. So the correct answer here would be a saw scale viper bite. That is E. Right. Next question. Right. So here we have another question with arthritis and rash. So 34-year-old school teacher who's been followed up at the rheumatology clinic for a small joint arthritis presents with a new onset rash of 2 weeks duration. On examination, there's a well-defined erythematous rash on the extensor surfaces of bilateral upper limbs at the back of the scalp, just below the hairline. On inquiry, she stated that the rash is sometimes itchy and a part of it is hairs off. So this rash that is present on the extensor surfaces as well as just below the hairline is quite classical of what we call as chronic plaque psoriasis, for which there can be topical treatment options as well as systemic treatment options. So the rash just below the hairline is we have to differentiate from another condition that can cause like this, that is called seborrheic dermatitis, or what we commonly refer to as dandruff. So how do you differentiate between dandruff and psoriasis is that dandruff or the seborrheic dermatitis will not extend beyond the hairline, but psoriasis will extend beyond the hairline. And psoriasis rash can be sometimes itchy and it can have fine scaling and it will be erythematous to violaceous in origin. And psoriasis also can have present with arthritis, which can sometimes even predate the rash. So when you have psoriatic arthritis, there are about 5 types of psoriatic arthritis. You can have isolated DIP involvement, that is distal interphalangeal joint involvement. You can have asymmetric oligoarthritis. You can have symmetric oligoarthritis, which can be very similar to rheumatoid arthritis. Then you can get a very deformed sort of arthritis that is known as arthritis mutilans, and you can get psoriatic spondyloarthritis also. So out of these options, so reactive arthritis out, rheumatoid is out, enthesitis is out, scleroderma is out. The answer would be psoriatic arthritis. Next question. Oh, very bad time for such a question, but you can try this question. So no answer seems to be coming, so suggesting that this may be a difficult question. So we will go into how we calculate this. So the number needed to treat is 1 over absolute risk reduction. So to calculate the absolute risk reduction, you must calculate the control event rate and then you should calculate the experiment event rate. So the controlled event rate here would be 72 out of 240. And the experiment event rate here would be 24 out of 120. So 24 out of 120 is 48 out of 240. So 72 over 240 minus 48 over 240 is equal to 24 over 240. So 1 over 24 over 240 is 240 over 24. That is 10. So the correct answer here would be 10B. Right. Last two questions. So we'll go straight into the question because we are running out of time. A 45-year-old female presented to the dermatology clinic with a right-sided wrist drop and a hypopigmented patch over the forearm for which she was started on rifampicin. So what do you think when you think about this? Right-sided wrist drop, a hypopigmented patch over the forearm, and she has been started on rifampicin. So this is leprosy that we are dealing with. So leprosy is treated with rifampicin, dapsone, and drugs like clofazimine, but patient has been started on rifampicin. So it's most likely the patient is having tuberculoid sort of leprosy. So 1 month later, she again came with erythema and induration of the previous lesion, severe pain and worsening of the weakness. So what is the most likely reason for her current complaint? So this is most likely what we call as a lepra reaction. So cellulitis, delayed hypersensitive reaction, drug eruption, herpes zoster infection, and thrombophlebitis. So uh, out of all this, all the possible answers, if you don't know about lepra reaction, would be B or C, whether it's a drug related process or whether it's a delayed hypersensitivity reaction. So there are two types of lepra reactions. That's called type 1 lepra reaction or a type 2 lepra reaction. Type 1 is called also as a reversal reaction. Type 2 lepra reaction is also called erythema nodosum leprosum. So type 1 lepra reactions occurs in borderline disease, that is borderline tuberculosis, borderline or borderline lepromatous, and erythema nodosum leprosum can occur in borderline leprosy or lepromatous leprosy. So in type 1 reactions, you get acute onset of redness and swelling in the leprosy skin lesions, and the lesion itself may ulcerate, and there could be edema, and there could be new nerve damage manifesting as numbness or muscle weakness. The treatment here would be steroids. And in type 2 lepra reactions, you can get new painful tender red papules or nodules. So new lesions do not appear in type 1 reactions, but new lesions can appear in type 2 reactions. And new nerve damage also can occur in type 2 reactions. And you can get a lot of systemic manifestations in erythema nodosum leprosum like fever, malaise, lymphadenopathy, and so on and so forth. Treatment again would be steroids. So type 1 would be a type 4 sort of hypersensitive reaction or a delayed type of hypersensitive reaction according to this gel and plumes things you learned in your immunology. And type 2 is an immune complex mediated thing. So it's termed as a type 3 gel and plumes type of hypersensitivity reaction. So type 1 is a type 4 reaction, type 2 is a type 3 reaction. So the correct answer here would be a type 4 or a delayed hypersensitivity reaction. That is a type 1 lepra reaction. Last question. We have a 79-year-old man presented with multiple ecchymotic patches. So he had multiple comorbidities. He was on statins and aspirin for ischemic heart disease. Statins usually do not cause ecchymotic patches, but aspirin can cause ecchymotic patches. And patient is on warfarin for atrial fibrillation. That again increases the patient's TD tendency. Enalapril and difedipine for hypertension and oral hypoglycemic agents for diabetes mellitus. So those usually do not cause ecchymotic patches. He had taken antibiotics recently for an upper respiratory tract infection. What is the investigation that is most likely to reveal the cause of the bleeding? So it's either aspirin or warfarin that is causing this, and it's most likely that the warfarin level has been increased because of the reduced metabolism of warfarin. So warfarin can inhibit the gamma carboxylation of vitamin K dependent clotting factors like 2, 7, 9, 10. And these are very important in the extrinsic pathway of clotting and where we measure using the PTINR. So the common antibiotics that we patients are prescribed for upper respiratory tract infections like clarithromycin or azithromycin or even erythromycin. And other antibiotics also can interfere with the cytochrome P450 enzymes and reduce the metabolism of warfarin, thus increasing the effect of warfarin and patients having higher INR. So the correct answer here would be prothrombin time with INR. Right, so D. So that is the end of the discussion today. Any questions on whatever we discussed?